Welcome to the deep dive. Today we are pulling back the curtain on a really massive issue, one that's kind of hiding in plain sight on the operational side of healthcare.
Yeah, specifically for therapy clinics. So think physical, occupational, speech therapy.
We're talking about the headache that is provider credentialing.
It sounds like, the most boring administrative topic you could imagine, but this paperwork,
That's true.
it creates this administrative drag that goes so far beyond just filing forms.
Right.
Credentialing is that required and often painstaking process of officially enrolling your new therapist with insurance payers. So commercial carriers, Medicare, Medicaid, all of them.
And our mission for this deep dive is to show you exactly why this slow, bureaucratic process should honestly keep clinic owners up at night. We're talking about these hidden costs that become very real, concrete financial losses. And I want to set the scale right away. Based on some industry reports, these credentialing delays cost the therapy sector and related fields over $1 billion a year.
$1 billion in lost potential revenue. That's just staggering. That's money that should have been generated by highly skilled staff who are just waiting for permission to bill.
So today, we are going to unpack how those delays translate into lost money, burnt-out staff, and maybe most importantly, blocked patient access.
And crucially, we'll finish with some practical strategies you can actually implement to stop this, billion-dollar administrative bleed.
But okay, before we jump into the dollars and cents, we have to do a quick definitional check, because you hear credentialing and contracting used together all the time.
Yeah, people use them interchangeably, but they're two very distinct hurdles you have to clear.
So what's the difference?
So credentialing is the first phase. It's the due diligence. The payers are verifying the provider's qualifications, proof of their license, their education, any specialty certifications. It's all about checking competence.
Okay, so that's verification. What's contracting?
Contracting comes next. That's the actual negotiation and signing of the legal agreement with the payer. It establishes the terms, the services, and most critically, the reimbursement rates.
And the order matters. Credentialing has to happen first.
Always. You can't have a contract with a payer if they haven't even verified the person who's going to be delivering the care.
And I imagine the complexity just explodes from there.
It multiplies because this entire process has to be repeated for every single payer. And a bigger clinic might work with, a dozen major insurers?
There are probably different plans within each of those insurers, right?
Exactly. Each one can require its own specific enrollment steps. It's a maze.
A maze that translates directly into, cold, hard cash loss, which I think is the perfect place to start, the revenue sinkhole.
Yeah, this is where the numbers get pretty stark.
Every day, a new therapist is hired, they're ready to go, but they're stuck waiting on a payer. It's a day of lost services.
The payroll clock is ticking, but the revenue clock is just frozen.
We found one figure that just crystallized this whole problem for me. Experts calculated that a single physical therapist could lose, roughly $50,000.
$50,916 to be precise, over a 4-month credentialing delay.
So just shy of $51,000.
Yeah.
Over 120 days.
And that estimate is probably conservative, to be honest. It's just based on a standard expectation of what a therapist can bill in a day. It's all the therapy that could have happened and been billed for, but wasn't.
Let's dig into the mechanics of that loss, because I think it really matters. When you say $50,000 in lost revenue, is that just the gross billings that were missed? Or does that also account for the fact that you're still paying the therapist's salary?
That's a great question. And that's the hidden part of the cost. The $50,000 is primarily the opportunity cost. It's the gross revenue from those missed appointment slots.
Okay.
But you're right, the net financial hit is so much deeper. The clinic hired them, paid for their onboarding, provides benefits, covers their salary for 4 months, often while that therapist is stuck doing, low-value admin work.
So you have a highly paid professional basically pushing paper.
Exactly. The clinic is absorbing their full salary plus losing over $50,000 in the services they could have been providing.
It's like paying for a high-performance engine just to let it sit idle in the garage. And this isn't some minor 2-week hiccup, is it? What are the timelines we're really looking at?
And that's the core of the problem. The timelines are long and they are wildly unpredictable. For big federal programs like Medicare or Medicaid, if it's a new application, you have to brace yourself.
How long?
It can easily take 90 to 180 days, sometimes longer. It really depends on the state and their current backlog.
Wait, 6 months. 6 months just to get approval to bill.
It forces clinics to operate on what we call an assumption of delay.
That's a great phrase.
Commercial payers might be a little faster. They might average 60 to 120 days, but you still have to bake in a minimum 3 to 4 month delay into your whole hiring cycle.
So if you don't get that paperwork in way in advance,
That $50,000 loss becomes an absolute guarantee, not a possibility, a guarantee.
okay, so that's the financial hit, which is staggering. But this has to create a ripple effect on the actual team, right? I mean, on the people.
Oh, absolutely. Which brings us to the human cost. Staffing, burnout, attrition, all of it.
I mean, you bring in this specialist, you probably spent months recruiting them, and then they're just stuck.
It creates this incredibly awkward, morale-sapping situation. You have a fully capable clinician, paid a professional salary, but they're legally barred from treating most of your insured patients.
It just seems like a perfect storm for exacerbating the healthcare workforce shortage we already have.
It is. You're wasting these valuable human resources, and you're pushing the burden onto your existing team.
Because the patients don't disappear.
Exactly. The patient load doesn't just vanish. The new hires capacity has to be absorbed by the staff who are already there, so they're taking on extra shifts, seeing more patients per day just to cover that operational gap.
Which, inevitably leads to massive strain. We saw Radiant Healthcare noted this specifically. They said onboarding delays, that frustration of being hired but kept on the sidelines. It frustrates clinicians and can lead to turnover.
And these are high-demand professionals. They're mobile. They will absolutely look for a clinic where they can actually start working and, earning their keep right away.
And if they leave, the cycle just gets worse.
Exponentially worse. The data on replacing a lost therapist is sobering. The cost to recruit, onboard, and train a replacement can run up to 150, even 200% of that clinician's annual salary.
Hold on. So if an average therapist makes, say, $80,000 a year,
Yeah,
the cost to replace them could be up to $160,000.
it can, yeah.
That one cost alone could just crater a small clinic's entire annual budget.
It absolutely can. You lose the revenue they would have generated, you have these massive direct replacement costs, and you've spread burnout across your entire remaining team. It's a self-reinforcing operational nightmare.
And the administrative team must be feeling this pressure constantly.
Oh, they're the ones chasing paper for 3 to 6 months, knowing the entire organization's stability, both financial and human, just hinges on them getting that one approval.
So we have the financial cost, the human cost.
Yeah.
But the real bottom line is always the person who needs the care.
Ultimately, yeah. Slow admin processes create direct patient suffering.
The delays halt care before it even begins.
We saw this really eye-opening example from health authorities in Kentucky. They found that these duplicative ID and credentialing checks create credentialing delays averaging 28 days. And their conclusion was that this hinders patient access to care.
And 28 days a month is so much more than an inconvenience.
In therapy, it can completely disrupt a recovery timeline. Think about someone who just had a stroke and needs immediate mobility work.
Right.
That recovery window, right after the event, is often the most critical time for brain plasticity, for retraining muscles. A month spent waiting for a therapist to get credentialed is a month of that crucial recovery time that could be lost forever.
And what about kids? Children who need speech or occupational therapy to hit their developmental milestones.
Exactly. A 4-week wait for paperwork could mean delaying a critical intervention during a developmental window that simply will not wait for an insurance company to catch up.
So this administrative lag actively creates a treatment gap.
It does. A patient might drop out. They might seek a less ideal alternative because their preferred therapist isn't in network yet, or the wait list is just too long. The quality of care gets compromised.
And I'm guessing this impact is felt more in some places than others.
Absolutely. In rural and underserved areas, the wait lists are already incredibly long because of chronic provider shortages.
So in those places, a month-long delay is.
It's the difference between care delivered and care deferred indefinitely. Every single day of delay is a missed opportunity for someone who might not have another local option. The bureaucracy literally becomes a geographical barrier to health equity.
Okay. So if the problem is this pervasive, this systemic, we need solutions. We need practical strategies.
And the good news, really, is that most of these staggering costs are preventable.
Preventable. I like that.
But it requires a pretty fundamental shift in how clinics think about and manage their administrative workflow.
The first step seems to be what you could call, aggressive early submission.
Yes. You absolutely must start the enrollment process before the therapist's first day, if it is humanly possible.
The goal isn't just to start early, though. It's to align the approval with the start date.
Right. It requires an almost predictive approach. You need to know which payers usually take 60 days and which ones will drag it out to 150, and you prioritize your submissions based on that therapist's expected caseload.
And this can't just be a task that's shared among 5 different people in the office.
No. The sources really emphasize you have to assign a dedicated lead, someone whose one focused job is to shepherd these applications through the bureaucracy. They're the tracker, the complier, the follow-up specialist.
Part of that dedicated role is mastering those centralized systems, too. I'm thinking specifically about maintaining updated CAQH profiles. For anyone listening who might not be in the admin office, what exactly is CAQH?
Right. CQH is the Council for Affordable Quality Healthcare. It's a nonprofit that runs this thing called the Universal Provider Data Source.
Think of it like a central, mandatory library for all of a provider's professional information. Their license, education, malpractice history, everything.
And most major insurance companies pull their verification data from that profile. So if your CAQH profile isn't fully updated, if it's not accurate, if it's not attested to regularly,
Then every single one of your payer applications gets immediately flagged and delayed.
Yeah.
It's the ultimate single point of failure.
it really is. Incomplete info at the source guarantees rejection downstream. Which brings us to efficiency. You have to automate what you can.
And this is where we see a real game changer. Hospitals that have implemented automated credentialing systems, they report efficiency gains that can cut processing times by up to 80%.
80%.
The software just handles all that repetitive data entry and tracking.
So a 6-month wait becomes, what, a little over a month? That's transformative.
Okay, but let me introduce a little friction here. If the technology exists to cut this time by 80%, why haven't all clinics, especially smaller ones, already adopted it? What's the real barrier?
That's the critical practical question. For a huge hospital system, the initial investment in that kind of software is easily justified by the sheer volume of providers they have. But for a small, 2 or 3 person clinic, the upfront costs can be prohibitive.
I see.
But what we are seeing is that smaller clinics can still find huge efficiency gains by using smaller automation tools for specific tasks. Things like license verification tracking or automated reminders for their CAQH deadlines. Partial automation is still exponentially better than doing it all manually.
That's a key distinction, and technology helps, but persistence is just as important. You can't just submit and forget.
No, absolutely not. Clinics have to follow up persistently. The process is so long, 90 to 180 days. You cannot afford to let an application just sit in a queue unchallenged. Constant phone calls, email tracking.
Yeah.
You have to document every interaction.
So that dedicated lead is basically a professional nag.
They are, and that persistence is what moves an application from the bottom of the pile to the top.
Okay, and finally, let's talk about that recovery tactic. The one that can claw back some of that lost 50 grand, retroactive credentialing.
This is where you ask the payer, once approval finally comes through, to let you bill for services all the way back to the therapist's actual start date.
But the policies on this must differ wildly.
Dramatically. They differ by payer, by state regulation. It's not a guarantee at all.
But it's worth asking the second that approval letter comes through.
Always. You have to ask. And having the documentation ready to submit for those retro billed services is vital.
Yeah.
If you don't ask, you are just leaving tens of thousands of dollars on the table. Period.
And we have to stress, this isn't a one-and-done event. It's a continuous cycle.
That's right. Most payers require recredentialing every 2 to 3 years just to maintain eligibility. And it's not a simple renewal. It's often navigating that entire process all over again.
Verifying licenses, checking for claims, updating everything.
Staying on top of those cycles is a non-negotiable part of operations.
So we spent this deep dive establishing that this administrative lag, this slow payer approval, it creates a vortex of financial loss, staff burnout, and really critical patient hardship.
The core lesson here is that bureaucratic inertia is incredibly expensive. And proactive management, so early submission, dedicated oversight, smart automation, persistent follow-up, that is the essential barrier between a solvent, stable clinic and one that's just suffering from chronic financial and staffing shortages.
So what does this all mean? We've established that the initial credentialing process for one new hire can take up to 6 months and cost a clinic $50,000 in lost revenue. And that's a one-time onboarding hit.
But The true continuous administrative burden is that mandatory recredentialing every 2 to 3 years. If a single 4-month initial delay costs $50,000 per therapist, just consider the cumulative overhead and the administrative risk involved in having to successfully navigate that long process, not just once, but every couple of years for every single therapist in your clinic. That cycle demands a massive commitment of internal resources.
So the final question is, what level of administrative commitment are clinics truly dedicating to this to ensure the continuous eligibility? And maybe more importantly, how much time are individual clinicians forced to spend on paperwork when they should be focused on patient care? That's the strategic challenge.
That's the deep dive.
We'll see you next time.